Today I'm going to speak on managing cataracts in post-traumatic situation. See, the trauma, when it occurs, you really do not know the extent of it. And post-traumatic, when a cataract presents, it can present in any which way. It could be as simple as a pupil which refuses to constrict, to, of course, corneal aberrations, corneal lacerations, leading on to, zonular ruptures or capsular tears. So what I'll do is basically the list can be endless. So I'll only focus on a couple of cases which I just saw recently. And this is a very interesting case. The patient was having his engagement, and on the day of engagement, the firecracker hits him, and he presents within 8 hours. The situation is, he has got, luckily, no corneal tear. There's a zonular rupture. There's vitreous in the AC. There's a posterior capsular tear from one end to another end, and a severe traumatic mydriasis. And all this combination really puts you in a tough thing. So I decide to go in for a Hoffman pocket to begin with, because if you ever intend to do that, it's always better that you do it on a closed eye where the pressure is well maintained. I keep my irrigation away and do a very minimal vitrectomy so that the vitreous in the AC is pushed back and cut. The whole exercise here is to ensure that my posterior capsular rupture is not disturbed. Obviously, in such a case, even if I am normally doing my rhexis with forceps, I would always make a small cut in the anterior capsule, and very, very gradually. Now, what you see here is the classic visco dissection, where cohesive viscoelastic is injected under the rhexis so that it creates a separation between the anterior vitreous face and your nucleus. Luckily for the patient, this nucleus is a soft one, because I'm operating within maybe 36 hours from the time of the injury. All along, my effort here is to ensure that the vitreous face is not disturbed, because everything depends on it. If the vitreous face is disturbed, then the whole exercise is to do anterior vitrectomy, and then there's a question of whether can you put the lens in the bag or no. You may have to intermittently keep injecting viscoelastic. And finally, the last few remnants of cortex plus the vitreous that has come from the zonular rupture is what is taken care. And in this bag, again a controversy comes. If you have a posterior capsular rupture, can you put an endocapsular ring? But yes, of course, you can put with a safety suture. And at the point where the leading tip starts going below the posterior capsule, you always have the suture to pull it out. But in this case, it behaves well, and the endocapsular ring with the two ends are within the bag on the right side of the capsular bag. So that means I have crossed across. So that means the capsular bag is very nicely stretched on all sides. And now is the time for me to use a segment. And the Hoffman pocket is created at the maximum zonular weakness. Here I am using the modified Gupta segment. The advantage of this is that it is tinier and it sits well in the bag. It is done by first bringing in that 9-0 needle from outside through the Hoffman pocket and taken it out through a 36 number. Once the segment is in place, the two sutures are pulled out of the Hoffman's pocket. Before I inject the lens, I suture the bag. When you suture the bag, ensure that your suturing is not very tight, because you don't really need it to be tight. And the biggest advantage of Hoffman pocket here is that those suture ends nicely go under, and next day you can't even see the suture. The next challenge here is to decide whether you want to put a 3-piece or a single piece. And with vitreous face not disturbed, single piece can go in. The trick is to get it in the sulcus and gradually nudge the haptics within. And once the haptics are placed, the next job is to clean up the viscoelastic, inject pilocarpine, then re-inject cohesive viscoelastic, because you also need to take care of the mydriasis part, which you can that's a small job here. After having done several pupilloplasties by most of us, the last bit of finishing touch in terms of giving a small circular pupil is indeed a good thing. And when this patient comes for a post-op 2 days later, he is unaided 6/9 part, which was a very happy thing for him and for me. And I haven't seen him after that because I was traveling abroad, but I'm sure he must be doing well, because in another 5 days time he's heading for his wedding, and he wanted to know if he can sit through that home and all that. I said, let's hope you can do it. This patient, this is my second case, and of course I'll finish with that. He came to me 7 years back with a corneal laceration, which was sutured by my corneal surgeon. There was a lot of tissue loss, and after 7 years, he comes with drop in the vision. And that drop is, if you look at the Purkinje image, it's right where he was seeing through. Naturally, he's taken up for surgery. And in such cases of trauma, when the rest of the zonules are healthy and strong, your cataract surgery per se doesn't really pose a problem, because rest of the zonules are taken care and there's hardly any phacodonesis. The question comes at the end because of the tissue loss, and this patient has a toric lens to be placed. Obviously, to get furthermore stretch in the area where zonules are lost, you would put an endocapsular ring, because you always want a 360-degree stretch in the bag. To begin with, I had no intentions of doing anything but to implant lens and come out. But then I realized that if you want this toric to function well, you have to pull the toric lens into the center. So obviously the least I can do is to use some segment and get the lens capsular bag as much to its normal position as possible. But in a long-standing case, when the bag is already pushed to one side, to get it to its original position sometimes is not very easy. Here I'm using the ASIA anchor. The reason I'm using ASIA anchor is that it is in one plane, and if I wish to do the iris manipulation on top of that, I want it to happen without much of interference from the central loop like in other segments. And once the segment is placed, then I try and attempt if I can get the iris mobilized, because it is very necessary that even if you are going to form a pupil, even if you are going to even do a small semblance of a pupil there, it still makes a lot of sense, because you do bring in refraction to the center of the cornea, and to whatever extent you can cut on the external glare. You try and do it. I'm just rushing it through. In these cases, whenever you have lot of tissue loss, it's technically little challenging to get the pupil to the center. But the experience has taught us that it is always worth trying it. And in the final picture, if you look at the Purkinje images and what I saw post-op, it did make a lot of sense in going through this exercise because patient did have excellent vision. I mean, excellent, meaning fairly decent vision. It was around 612. Do I have time? No. Can I take another couple of?
Yeah, of course.
Okay. It's okay, no? Yeah.
Absolutely.
See, when it comes to trauma, a trauma can be a trauma that happens outside or a trauma that happens by us during the surgery. And it's also very important that we just remember that we don't cause more harm to the eye when we operate. Now here is a classic case where the surgeon went in for a surgery. The surgeon was doing small incision cataract surgery, and after the nucleus was out, the entire lower root of the iris was torn, and this patient was brought to me 2 days later, and there was an intact rhexis, but there was a lot of cortex. First, it had to be cleaned up. Now, these are very, very tricky cases when the amount of iridodialysis is very extensive. And it's also challenging because at the end of the case, if you can really get that iris back in place as it was before, more than the patient, it gives you that kick. And very often, after doing routine cases all along, once in a while when you get to do such cases, it gives you that surgeon's kick that you actually are looking for. The exercise here is first to clean up the capsular bag, get the lens in place, then you plan your strategy. I do a complete, I open up the adhesions from the limbus, limbal peritomy, and what I do is the shoemaker stitch where you use a large needle through which the nino suture is threaded, and it's an attempt where you use the microforceps to hold the edge of the iris. The suture, it's a double arm needle suture where the first needle is taken out, and subsequently every bite that you take through a peripheral iris and out, you just very gently take the loop out and pull back the needle. So you create several loops in the periphery. So that the loop doesn't slip, you can always put the first needle through that. Every time the needle comes out, just hang on to that loop before the needle is withdrawn back. So like that, at the end, you have 4 or 5 loops through which your first needle has passed, and finally the needle is taken out so that you take one stitch at the end of it, after making sure that that iris is properly placed in the sulcus. Well, it's little time consuming because you don't want the suture to tear here and there. And once your pupil is really well created in the center with peripheral iris in place, you try and use bimanual to remove the viscoelastic and also to slightly tug on the pupillary edge to create a circular pupil, and then of course the reflected conjunctiva is stitched back. So these are 3 cases I thought I would share with you. And Dr. Anaga, I would like to thank you for this invitation. But I wish you had a better timing, so at least there were people who would have watched it. But I
Absolutely.
thank all of them who are here. It's a wonderful course with lovely speakers. Thank you so much.
Thank you so much, sir. I think a big round of applause for Dr. Haldipurkar, sir. And I think we are fortunate to have actually witnessed these cases. They are absolutely amazing. I think you are a true craftsman and so much to learn from you, sir. We are blessed, and I think all those who haven't come here have really missed something. Thank you so much.